Hello, welcome to the conferencing system. Please enter the conference number followed by the pound key. Please enter the conference number followed by the pound key. Please enter the conference number followed by the pound key. Please enter the conference number followed by the pound key. Please enter the conference number followed by the pound key. Please enter the conference number followed by the pound key. Please enter the conference number followed by the pound key. Please enter the conference number followed by the pound key. Please enter the conference number followed by the pound key.
Test. Yeah, that's live.
So you might want to put it just a little bit lower.
Okay.
Good afternoon. Welcome to Grand Rounds. It's my pleasure today to introduce our speaker, Dr. Greg Root. He's going to be speaking to us today on mixed clear cell and serous carcinoma of the ovary. Our program is underwritten by an educational grant through OSU Medical Center, Graduate Medical Education, and a disclosure statement has been signed as on file in their GME office. Dr. Root completed his Bachelor of Science degree at Oklahoma State University in Stillwater, Oklahoma in 2006. He then completed his Doctor of Osteopathic Medicine at Oklahoma State University College of Osteopathic Medicine in 2011. And Dr. Root is currently a senior OBGYN resident here at OSU Medical Center and is one of our co-chiefs of our Chiefs Council. It's my great pleasure to introduce Dr. Greg Root.
Well, thank you, Dr. Alexopoulos. Thanks for that introduction. Good afternoon, everybody. Good afternoon to the people that we're teleconferencing over to. I'll tell you why. This is a humbling experience to stand in front of you guys. It's been 8 years in the making, and to be a senior resident and been on everybody's service, basically, and worked with many of you on consults. You guys are brilliant. And I just really appreciate the opportunity to speak with you. And the medical students, I really appreciate you being here as well. We could put you up against probably all of the medical students in the nation and be pretty proud. So thanks for being here. Let me tell you a little bit of how this presentation is going to go. I don't know about you guys, but sometimes I read a book or I read a journal and it just never sticks. And then I see a patient or somebody presents a patient and it starts making sense to me. So I'm going to start with a case presentation of a patient that I took care of when I was on my gyn-oncology service. And then we're going to go into like some general ovarian carcinoma, looking at it generally. And then we're going to get into mixed clear cell carcinoma, which is very rare. This case presentation, although this is a very rare cancer, it presents in a very common way. So you can kind of see how ovarian cancer presents. So let's move on. So let's meet our patient. This is a 59-year-old G0P0 who is complaining of abdominal fullness and constipation for the past 3 months. She was recently seen by her primary care physician and worked up for possible cholecystitis. An incidental ovarian mass was found on imaging. She was referred to our service and scheduled to have a transvaginal ultrasound. But the weekend prior to the ultrasound, she presented to an outlying emergency room complaining of 8 out of 10 abdominal pain. This pain was not relieved with medication. It was sharp. It had radiation to her back. A CT at the outlying hospital was performed, and it showed 2 large ovarian masses. Secondary to the patient living greater than 1 hour from a tertiary care hospital, and then the lack of gyn-oncology service in her hometown, she was admitted for observation, and gyn-oncology was then consulted. This is her past medical history. You can see it's pretty straightforward. She had menarche at 13, coitarchy at 16, menopause in 2013 with no history of an STD. Her last pap smear was in 2011 and was within normal limits. Her mammogram was in 2011 as well and also found to be benign. She's G0P0, allergic to penicillin, and only takes lactulose PRM for constipation. She's not a smoker, does not consume alcohol, and no history of drug abuse. She's a counselor, lives with her husband. Did have a family history of lung cancer in her mother. However, she couldn't remember the age at which her mother passed away from that disease. This is her review of systems, really straightforward. I'm not going to read those to you, but I'm going to skip down to genital urinary. You can see there was no dysuria, no hematuria, no vaginal pain, no vaginal discharge or dyspareunia, but GI. She didn't have nausea or vomiting, but she presented with constipation, which is very common, and she had abdominal bloating for the past 3 months. Her skin and breast showed no rash, masses, or discharge, and then the rest of it's very straightforward, except for that she was having a little bit of a depressed mood, is what she would call it, over the past few weeks. Can't really explain why. Her physical exam was pretty straightforward. Vital signs were normal. She appeared her stated age. She was in no acute distress. The rest of those are very straightforward. But let's look at her abdominal exam. She was distended, positive tympani, positive tenderness to palpation in the lower quadrant bilaterally. She was guarded, but negative peritoneal signs with her heel tap test. This was significantly different than when she was seen in the office just a couple of weeks before. So we ordered some labs. So here they are. She had a CA 125 that was just sky high at 634.8. Her CEA was 0.5. You can see her CBC there and her CMP. AST, ALT were elevated at 70 and 84. We got a hepatitis panel that was negative, and the EKG showed a normal sinus rhythm. So here's the imaging that we obtained. We had a transvaginal ultrasound, showed a very complex, solid cystic mass that was multilobular, measured 9.5 by 8.2 by 10.9. There also is a second complex solid cystic mass directly adjacent that was measuring 6.1 by 7.7 in the pelvis with a moderate amount of pelvic fluid. At that point, we ordered a CT of the abdomen. We had two complex multiloculated pelvic masses that were congruent with the transvaginal ultrasound. You can see their measurements there. Had a large volume of ascites with omental caking, retroperitoneal and pelvic adenopathy with possible metastasis to the cirrhosis. So you can see pretty extensive disease. CT of the chest, however, was clear of any metastasis with some right hilar adenopathy. So we took her back for surgery, which is kind of the standard of care and the cornerstone of treatment. She received an exploratory laparotomy with evacuation of ascites, supracervical hysterectomy, which is not what we normally do, but the disease was just so invasive in the pelvis that we just could not get that cervix out. She had bilateral salpingo-oophorectomy and omentectomy, radical dissection with tumor debulking with an ultrasonic aspirator, and pelvic and periaortic lymphadenectomy. We had an indicated appendectomy, and you'll see in the findings why. And she had a right hemicolectomy with anastomosis. We had very minimal blood loss at 550 for this pretty big surgery. These were the surgical findings on this woman. She had 3 to 4 liters of serous ascitic fluid. She had adhesions of the small and large bowel secondary to malignancy, peritoneal carcinomatosis, large omental caking, significant deposits of malignancy on the colon, the appendix, which appeared almost completely replaced by malignancy. She also had a bilateral cystic ovarian mass of the right ovary that was roughly 15 to 20 centimeters in diameter, and then the left was closer to about 10 centimeters in diameter. She had extensive lymphadenopathy as seen on pre-op imaging that was largely resected. However, this is very important. We're going to talk about this later. There was a palpable 2-centimeter node superior to the right renal hilum that could not be removed. And the peritoneal disease was debulked down to largely less than 1 centimeter nodules, but multiple areas throughout were 1 to 2 centimeters that were not able to be safely removed, secondary to deep infiltration of the small bowel. And 90% of the disease was removed, and any disease that remained was roughly 1 to 2 centimeters in diameter. We'll talk about that a little more. Frozen section. We sent for frozen section. We got called back in the OR. Indicated that these were high-grade serous carcinoma of the ovary. Frozen section of the colon and appendix was suggestive of metastatic disease rather than a second primary in the area of the cecum and the appendix. Bilaterally and widely, so this is the pathology report that came back. Bilaterally and widely metastatic high-grade ovarian carcinoma. The majority estimated to be 80% of the neoplasm is poorly differentiated, grade 3, clear cell carcinoma, and we'll talk about how rare this is. The pattern was present in all sites. Minority is represented as a well-differentiated to poorly differentiated, so grade 1 to 3 serous carcinoma and approximately 20% of the tumor burden, and found in sites including the cystic right ovary, the left fallopian tube fimbriae, and the serosa of the small intestine and the colon. The histological classification then came back accordingly, mixed clear cell, and serous carcinoma. This is just her hospital course, kind of afterwards, kind of how they're managed. She was well controlled postoperatively with Dilaudid PCA, and she was on IV Tylenol. And then after that, switched to PO Percocet and was tolerated really well. Her diet was advanced once the patient began passing Cladis and was tolerated well. But on post-op day number 4, she developed a fever, 38.2 degrees Celsius, and leukocytosis of 14. She was tender to palpation, had erythema around her incision. Levaquin was began. However, over the next 2 days, her fever did not resolve. White blood cell count took another jump at 18.2, and this incision began to have a serous anguinous drainage. So on day 7, we began gentamicin and metronidazole. The erythema resolved over the next 48 hours. The patient remained afebrile. She became ambulatory and voided appropriately. She had appropriate bowel movements. At that point, we felt comfortable discharging her home, and we lost her to follow-up. She actually transferred care to another gynecologist across town, one that we work with, and I actually was able to follow her. Unfortunately, this woman passed away, and we're going to talk more about this cancer and how it acts, and you can know more. And I'll talk to you more about it later in questions if you want to know more about her case and the treatment that she had. So let's move on to an overview of ovarian cancer. Epidemiology, it is the 5th most common cause of cancer in women, and it is the 2nd most common gynecologic cancer behind endometrial cancer. It is the #1 cause of gynecologic mortality, and it's the 5th ranking cause of all cancer death in women. So it's pretty lethal. 1 in 7 women will develop ovarian cancer in their lifetime. That's a 1.6% lifetime risk in the normal population. Ovarian cancer is more common in northern European countries, Northern America, than in Asia, developing countries, or southern continents. The etiology of ovarian cancer is still very well unknown, but most widely accepted theory of the etiology is that ovulation results in genetic injury to ovarian epithelial cells, and the sufficient cumulative damage leads to cancer. And so we're going to see that in this next slide when we look at the risk factors here. Advancing age, median age of diagnosis is 63, and the median age of death is 71. But look at these here: null parity, early menarche, late menopause, infertility, all things that lead to more ovulation, which goes to that theory that we talked about. Family history plays a very significant role. We had 1.6 lifetime risk in the general population. It moves to 5% lifetime risk with 1 first-degree relative, and up to 15% lifetime risk if 2 first-degree relatives are diagnosed with ovarian cancer. Next is BRCA1, BRCA2. I think we're all very familiar with this, and then Lynch syndrome. Lynch syndrome has a 12% lifetime risk, but if we look at BRCA1, it jumps up from 1.6 to 39 to 46% lifetime risk, and BRCA2 is 12 to 20% lifetime risk, so very significant. So despite the very high risk of women with these families with hereditary ovarian cancer, they only compromise 10% of all ovarian cancer cases, which I think is very interesting. Are there protective factors? Sure. Oral contraceptive use for greater than 5 years. Oral contraceptives offer a 50% reduction in ovarian cancer if taken for as little as 3 years, but new research shows that increase each year after that shows a decrease in the likelihood of ovarian cancer up until 6 years. And then after 6 years, the increase in benefit seems to no longer be there. Why oral contraceptives? Why do they help? We're not really sure, but it's likely because the decrease in ovulation cycles. And is it the estrogen or progesterone? Well, the World Health Organization did a study in 2012. It showed no decrease with the use of medroxyprogesterone, which we all know inhibits ovulation. But in that same study, they showed increased risk reduction for higher potency progesterone oral contraceptive pills. So the jury's out, basically. We need more studies, more case-controlled, randomized controlled trials to say if what chemoprevention is with progesterone or estrogen alone. The other one is tubal sterilization. That one kind of kind of baffles me when you think about ovulation maybe being the reason. But coming out in the Green Journal in 2012, we had a study that showed that primary tubal cancers were a lot more than we thought. And there was a suggestion from the American Congress of Obstetricians and Gynecologists to start taking them prophylactically in hysterectomy, and they saw a decrease in ovarian cancer. So looking back on the old research, were they ovarian primary or were they tubal? We don't know. Women who've given birth to at least one child, which she has breastfed, and then a prophylactic hysterectomy and bilateral salpingo-oophorectomy. Is that good for everybody? No, a prophylactic surgery is recommended by ACOG only for hereditary ovarian cancer syndrome families. So that's the BRCA1, BRCA2, or Lynch. This risk-reducing surgery should be recommended to those women by the age 40 or when childbearing is complete. This is crazy. This will decrease their risk by 85 to 90%. It also will decrease a BRCA carrier's risk of breast cancer of 40 to 70%. I had a student one time ask me why 40, because y'all are so inquisitive. It's because, I had to look it up, 3% of BRCA carriers will develop ovarian cancer before the age of 40. Screening. There is no proven effective method for screening. Therefore, routine screening for women at average risk is simply not recommended. Annual gynecologic examinations with pelvic examination is recommended for preventative health care, which is what we do at all of our well women. So with this, who qualifies for increased screening and does it help? Well, any woman with 2 family members having ovarian or premenopausal breast cancer before the age of 50 among their first or second relatives should be referred for genetic counseling and potential BRCA testing. This is a recommendation from the college. If the BRCA is positive or they are positive for Lynch syndrome, we can consider vaginal ultrasound and CA-125 assessment every 6 to 12 months, starting at the age of 30 or 10 years before the diagnosis of the closest family member. This has yet to show improvement in survival or outcome. So you've got to educate your patients over the risk of this, and that this is level C evidence, and there's no case-controlled trials proving this to be effective when compared to the prophylactic surgery that we mentioned earlier. What are the signs and symptoms? As you can tell, these are very similar to the patient that we presented. A pelvic mass on physical exam, a solid, irregular, fixed pelvic mass is highly suggestive of an ovarian malignancy. Ultrasound signs of malignancy include an adnexal pelvic mass with areas of complexity such as irregular borders, multiple echogenic patterns within the mass, and dense multiple irregular septa, and presence of peritoneal fluid, and also CA-125 elevation. The symptoms are very vague. They could be confused with a less serious diagnosis very easily. They can consist of increased abdominal size, pelvic abdominal pain, bloating, urinary frequency or urgency, fatigue, constipation, back pain. The list goes on, and unexplained weight loss or early satiety. I thought this was a good time to talk about when is recommended by ACOG of when do we refer these people to a gynecologist. And you're going to see later that I'll have some statistics for you of how having adequate debulking and the correct surgery saves people's lives. And this is the recommendation from the college. It's divided into postmenopausal and premenopausal women. Your postmenopausal women who have a pelvic mass that's suspicious for a malignant ovarian neoplasm, as suggested by one of the following: elevated CA-125, ascites, nodular or fixed pelvic mass, evidence of abdominal or distant metastasis, and a family history of 1 or more first-degree relatives with ovarian or breast cancer. Those are the people that you refer on. In the premenopausal women, it's exactly the same criteria, but it's a CA-125 greater than 200 would be in your premenopausal women. The diagnosis is made from oophorectomy and histological confirmation. The staging classification is based on surgical evaluation and removal of as much tumor as possible, which is the cornerstone of treatment. And we're going to go over that here a little bit later. So here's the histology, and just kind of a brief overview. Ovarian tumors usually are categorized by the tissue of origin, which are epithelial, germ cell, and sex cord stromal, and that's the umbrella. And so then we have epithelial tumors, which are 85% of all cases, and that includes your serous, mucinous, endometrial, clear cell, and transitional cell cancers. Your germ cells, which are 10% of most of tumors, includes your teratomas, dysgerminomas, endometrial sinus tumors, and your embryonal carcinoma and choriocarcinoma. And then the sex cord stromal is only 5%, and that's your fibromas, granulosa cell, Sertoli-Leydig, and thecomas. So if you can see, 85% are epithelial cell tumors. And then this next slide kind of breaks it down even more. If we just look at epithelial ovarian cancers, 40 to 50% are serous tumors. 15 to 25% are endometrial tumors, 6 to 16 are mucinous tumors, and 5 to 11 are clear cell. So 1.6% lifetime risk of getting ovarian cancer. Of that ovarian cancer, 85% are epithelial, and of those 85%, 5 to 11% are clear cell. So this patient has a pretty rare cancer. Transitional cell, mixed epithelial, and undifferentiated carcinomas are encountered a lot less frequently, and she even has a mixed. So this is the World Health Organization histologic classification of ovarian carcinoma. You guys can read that. I don't need to read that to you. But let's take a look at clear cell carcinoma. This is a very generic slide. You can see that there's I think it's right in here. We're looking at a hobnail cell. Most frequently associated with endometriosis, clear cell adenocarcinoma has hobnail cells that are characteristic. In clear cells, the visibly clear cytoplasm results from the dissolution of glycogen as the tissue specimen is prepared histologically. Hobnail cells have bulbous nuclei that protrude far into the cytoplasmic lumen beyond the apparent cytoplasmic limits of the cell. If you're having histology flashbacks, I'm sorry. Here's a look at clear cell adenocarcinoma. It accounts for less than 5% of all ovarian malignancies. Worldwide, each year, approximately 138,000 women will be diagnosed with epithelial ovarian cancer, and of those women, approximately 14,600 will be clear cell adenocarcinoma. When compared to serous adenocarcinoma, clear cell carcinoma is more likely to be diagnosed at an earlier stage, but is often associated with a larger pelvic mass, and its bilateral occurrence is very rare. It's well known this tumor is one of the absolute most aggressive and malignant tumors of the epithelial ovarian carcinomas with a high frequency of lymph node metastasis. And you'll see why that's important later. According to recent large-scale studies, advanced stages of clear cell carcinoma have a much poorer clinical outcome when compared with serous histology, which is what our mix was, and a higher rate of relapse within 6 months of completing the first line of chemotherapy. So for recurrent clear cell carcinoma, the response to salvage chemotherapy was reported to be less than 10%, with a median survival of 6 to 9 months. So it's very deadly. Let's talk about staging. How do you stage this? This is surgically staged. The classification is based on surgical evaluation and removal as much tumor as you possibly can get. Proper staging requires a generous lower and upper midline incision, meticulous exploration with multiple peritoneal and nodal biopsies. The appropriate performance of staging operation really requires the understanding of how does this cancer spread. It spreads through exfoliation of the cells, it spreads lymphatically, and it spreads hematogenously. Lymph node metastasis increases with increasing stage of disease. So to give you an idea, stage 1 has a 15 to 20% risk of lymph node metastasis, where stage 3 has an 80% risk of lymph node metastasis. And both pelvic and para-aortic nodal drainage patients need to be evaluated because ovarian cancer can spread to the infrarenal aortic and the pericardial nodal chains. And then you need to think about, this is probably Dr. Poe, one of his favorite questions, I see him over here, is the drainage of the ovarian vein. So the left drains to the renal vein, where the right drains to the inferior vena cava. So the operation is, if you're going to perform a staging procedure, is much like the one we saw in our patient, which is exactly it, a total abdominal hysterectomy, which total means including the cervix. That's always, people get confused about that a lot, that a total hysterectomy means the ovaries. That's not it. Total includes the cervix. Then a bilateral salpingo-oophorectomy, omentectomy, peritoneal washings, peritoneal biopsies, a pelvic and aortic lymphadenectomy, liver biopsy if a visible lesion is seen, and an appendectomy if you're suspicious for mucinous carcinoma or if the visual tumor is spread to the ovary, like in our case. This is just a look at the 2013 International Federation of Obstetrician and Gynecologists staging system for ovarian cancer. Stage 1, the tumor is confined to the ovary or ovaries and fallopian tube, and you can see it's into 1A, 1B, 1C. The most significant jump in treatment, and we'll talk about it a little later, is the jump from 1B to 1C. 1A and 1B means that it's combined to the fallopian tube, and the ovary capsule is intact. No tumor is detected on the surface of the ovary or the fallopian tube, and malignant cells are not in your peritoneal washings, or you don't have ascites. So that's either 1A, which is unilateral, 1B, bilateral. 1C is when you have your straw. And so if you have, basically, if you have rupture of the tumor, if you have ascites, if you have washings, or if it's broke the surface of the ovary, at that point, then you have to do chemotherapy for treatment. And that's kind of the stopping point. The only exception, because of course in medicine we can't make it easy, there's got to be exceptions to the rule, right? Or it wouldn't really be learning. 1A, 1B, if it is stage, or if it's grade 3, or if it's a clear cell, then you also have to do chemotherapy. If not, then you can just follow these people after surgery. And we'll talk a little bit more. Stage 2, the tumor involves one or both ovaries or fallopian tubes with pelvic extension or primary peritoneal cancer. Stage 3, which is what our patient had, the tumor involved one or both ovaries or fallopian tubes or primary peritoneal cancer with confirmed spread to the peritoneal surfaces involving both pelvic and abdominal peritoneum or abdominal peritoneum and metastasis to the retroperitoneal lymph nodes. And then 4 is distance metastasis. So the treatment is surgery. Patients who undergo optimal cytoreduction have improved response rates to chemotherapy, prolonged disease-free survival, and improved overall survival. Optimal disease occurs when the residual tumor is 1 centimeter or smaller. Suboptimal disease occurs when it's stage 3 or stage 4 and the residual tumor is larger than 1 centimeter, which is our patient. Overall survival of patients with advanced ovarian cancer and optimal cytoreduction, this is kind of the take-home message, 47 to 66 months compared to 33 to 36 months for patients who are suboptimally debulked. So we go from 33 to doubling their life expectancy at 66 if you optimally debulk the patient. So that's why those recommendations came out in the practice bulletin in 2012 of the referral to gyn-oncology. And here's a look at treatment. This is the treatment recommendation by the Society of Gyn-Oncology of a grade 4 or a suboptimal disease or both. Ours was stage 3 suboptimal. That's why she falls into this category. You want maximal surgical cytoreduction with a combination chemotherapy of carboplatin and paclitaxel. 1A and 1B, we talked about earlier, they're adequately surgically debulked. I'm just going to review this. Need no adjuvant chemotherapy with a 90% of cases have a disease-free survival, which is pretty big. 25% of ovarian cancers, however, are stage 1, but 30% that appear clinically stage 1 will be upstaged, which will change the treatment. If you diagnose stage 1 without appropriate surgical staging, if you don't have surgical staging, platinum-based chemo is recommended, or you can counsel the patient and they can consider having a repeat surgery to go in for adequate staging. And then if that is negative, they wouldn't have to continue on with the chemotherapy. How do you prescribe, or how do we do IV carboplatin and paclitaxel? It's every 21 days for 6 to 8 cycles. When we talk about, there's a lot of discussion and a lot of change in the literature recently over ovarian cancer, epithelial ovarian cancer, and how you deliver the chemotherapy. So is it IV, or now we're talking about intraperitoneal chemotherapy. So the recommendation from the society is IP, or intraperitoneal cisplatin, along with IV chemotherapy in stage 3 that's adequately debulked. So our patient did not qualify. She was not adequately debulked. It's shown an increased survival of 65.6 months versus 49.7 months in the IV chemotherapy group alone. So significant increase. But when you're talking about IP cisplatin, you got to remember that you got to think about when they reviewed a lot of the studies, they recommend 6 rounds, and the average patient made it to 3, secondary to the gastrointestinal problems that come with IP cisplatin. So it's just not very well tolerated, but we still saw these results even though it wasn't tolerated to the full recommended treatment. 70 to 80% of advanced disease will obtain clinical remission. However, most will die of recurrence and chemotherapy resistance, which is it makes this a very sad disease. What about recurrence? It's most likely looking at extension of life. The best survival rate are with remission greater than 1 year with a long platinum-free interval. That's the best prognosis. They were treated with platinum, the cancer responded, and they went a year in remission. That's our best survival with recurrence. Also, isolated recurrence is another thing that increases their chances. Repeat debulking is an option, but it's a topic of debate. And with chemotherapy, with platinum and taxane, if they develop resistant treatment, becomes very highly individualized. So cancer recurs, and if it's isolated, so we don't have spread to other organs like the lungs or the liver, that type of thing, if we're looking at something that's pretty isolated, a small tumor, you can talk to the patient about reoperation, debulk that cancer. They have a higher chance of survival if that can be done, and then treating them with the cisplatin, or with the carboplatin, and paclitaxel. And then if that becomes where it is that this cancer develops to become resistant, it's very individualized. There's not just a whole lot of literature out there of what works and what doesn't work. Some of the really common treatments for that is etoposide, doxorubicin, and topotecan and they usually do it in monotherapy. So back to our patient, the one with clear cell, that cancer was very resistant to platinum therapy, and they tried platinum therapy. Still, she didn't do well on it, and when she was presented with the idea of what she could do, we could try other things. She was having a lot of problems tolerating it, a lot of the gastrointestinal problems. She had the neuropathy associated with taxane therapy, and she chose just to go home and try herbal treatment. Basically, she did get better because we stopped the chemotherapy, and then we consulted hospice, and the woman passed away. But that's kind of my brief overview of ovarian cancer. It's my sources or whatnot. Are there any questions? Thank you for your time.